long COVID-19 isn't just an adult issue, it's showing up in our schools. So, what does that mean for communication, learning, and participation? Well, today we are joined by Cassandra Natali and Abigail Sprague to unpack the latest research, real world case studies, and strategies that empower SLPs to support students affected by long COVID. So, get ready to connect with science with the school setting right here on School of Speech, presented by Speech Therapy PD. Hello, everyone, and welcome to School of Speech, presented by Speech Therapy PD. I'm your host, Carolyn Dolby, and I am so glad you are tuning in today, and you will be too. This episode is titled Supporting Students with Long COVID-19 in the Schools, and we are joined by two fantastic guests, Cassandra Natali and Abigail Sprague. I've got some quick housekeeping, so hold on for just a minute. I'm going to do our disclosures. Cassandra receives a salary for her full-time employment as a clinical instructor at Binghamton University, and Abigail has no relevant financial disclosures, and neither have non-financial disclosures to disclose. For me, I am a salaried employee for Portland Public Schools, and I do receive compensation from Speech Therapy PD for hosting School of Speech, and I have no non-financials to disclose either. Don't forget that each episode of School of Speech is offered for 0.1 ASHA CEUs through your Speech Therapy PD account. All right, before we get started, I want to tell you a little bit about our guests. Cassandra is a clinical assistant professor at Binghamton University and brings over 10 years of pediatric experience. Her focus areas include school-based services, social-emotional learning, language in emergent literacy development in preschool populations. She has also presented across the nation and is the recipient of several awards for her work in the schools. Abigail's here today, and she is a graduate student, at MGH Institute of Health Professionals, and she earned her bachelor's degree from Binghamton University in 2025, and she was studying vocal performance, that's dear to my heart, so is my daughter, and speech and hearing sciences. So I cannot wait till we kick into this. I want to get into this. I think this is going to be a really fascinating topic for our listeners because I think, we've heard about long COVID-19, and so let's welcome Cassandra and Abigail. Hi, Cassandra. Hi, Abigail. Hi. Hey. I know that there's just been, there's a lot more research, I think, and we'll get into that on adults and there's kids. So I think this is going to be fascinating for our listening audience. But before we get started, I always love to find out your journey. And most specifically with you two, I want to know your meet cute.
So I first met Miss Natali or Cassandra when I enrolled in clinical phonetics, which was my first ever speech language pathology class back in summer of 2022. She offered optional weekly Zoom sessions, and I was the only student to show up, so we would just talk one-on-one.
Need the review either.
She, liked making sure that she was doing her due diligence as a student.
I love this.
Yeah, so in the Zoom sessions, we would just talk about the specialties in the field and her experience at graduate school, and honestly, just how much she loves the career. And this really sparked my interest in speech-language pathology. And since then, I've had the privilege of working with her through a summer internship, observing her work with preschool students. And during that time, that's when I told her about my interest and some of the research I had already done on long COVID. So that's actually how we came together for this research project.
Yeah, we offer an internship, and Abby signed up for, I think, 4 or 5 sections of the same internship over and over again, where we focus solely on the work on long COVID. And it finally got to a point where I was like, you don't have to pay for these credits. We could just do the work.
I love this. So it's like the stars aligned and you found each other, and then boom, research happened.
Yep.
Right. I love that. Okay. I love that. I'm real familiar, honestly, about long COVID. So I'm just wondering, I'm thinking that maybe our listeners might not either. If you don't mind, maybe starting us off with maybe some of the common symptoms that we would see specifically in our pediatric population, perhaps?
Yeah. So I think it's probably helpful to start with defining what long COVID actually is.
Perfect.
There's so many different terminologies to refer to long COVID. It's also known as like post-acute COVID-19 syndrome, long haulers, post-sequelae of COVID-19. So there's so many different terminologies and terms to go about that. But according to the World Health Organization, long COVID refers to symptoms that persist for at least 3 months after the initial COVID-19 infection that cannot be explained by any other medical condition. And long COVID, it can affect multiple body systems, which means that symptoms look different from person to person. So that's part of what makes it so challenging, both to diagnose and treat, because there is not this one size fits all approach. The symptoms also vary widely. Some people, the duration of the symptoms, some people report gradual improvement over time, while others report lingering symptoms that can last for years. So generally, across all age groups, individuals with long COVID often report things like fatigue, memory disruptions, brain fog, or difficulty concentrating, headaches, shortness of breath, or anxiety or mood changes, decreased stamina, stomach pain, dizziness, heart palpitations, and muscle or joint pain. You can see there's just a wide range. And early on, researchers believed that children with long COVID experience symptoms similar to those seen in adults. But more recent studies have started to show that it can actually look quite different across age groups, even within the pediatric population. So new research as of summer 2025, late 2024, by Gross, it highlights how symptoms can differ even between infants and toddlers, preschoolers, school-age children, and adolescents. So it's very interesting.
Yeah.
Wow.
And it's really interesting that that shifted from when we started. And
Mhm.
there's not a whole lot of research on long COVID because it is so new, right? This didn't happen until about 5 years ago when COVID popped up, COVID-19 popped up. And a lot of the studies began in the adult population thinking that children did not experience these symptoms at all. And so the initial studies were kind of like, yes, children do experience long COVID. It can happen for children as well. And then even like our research and the work we did on training educators on symptoms and how to work with students with long COVID is already outdated because we're learning this new information that it really does shift per age group more than they initially thought that it did.
Mhm.
So since uh, we're going to be looking at our, school age children, but that goes from 3 to 22. I mean, right there is a large age bracket. And what does it look like for the different ages?
Yeah. So we looked more so from age actually 0 to 17. That's kind of where the research is staying within. So for infants and toddlers, some of the symptoms that are maybe unique or prevalent within this age range are trouble sleeping. They may have fussiness. They may have poor appetite, maybe a stuffy nose or a dry or wet cough. For preschoolers around age 3 to 5, they may also have a dry cough. They may have a daytime tiredness, sleepiness, or low energy. When it comes to the school-age children, they may have trouble with memory or focus. They may have back or neck pain, stomach pain, headaches, phobias. They may have refusal to go to school, itchy skin or rash, trouble sleeping or nausea, lightheadedness, and dizziness. And adolescents, we're seeing the most symptoms. So change or loss of smell or taste, body or muscle or joint pain. Again, this daytime sleepiness or low energy, fatigue after walking, back or neck pain, trouble with memory, lightheadedness, or dizziness. So this is all Gross's research that is just coming out.
Yeah. And Carolyn, I know you mentioned that, school age does go to age 21. And the reason why we only looked into age 17 is we were specifically looking at that pediatric population that once you turn 18, you fall under the adult population in everywhere else but the school district where we still take care of you until you're 21. So that was more specifically why we were looking at that, just the pediatric age group for that. And as Abby said, there's a lot of symptoms that can go with this. Not everyone is going to experience all of those symptoms, and not all of these symptoms fall under the scope of the SLP. But a lot of them, and the big ones that we think of going with this, especially like the memory loss and brain fog and trouble concentrating, are all things that we can really work on in the school. Even that persistent cough can affect, vocal hygiene that falls
Mhm.
under our scope of practice as well.
I mean, yeah. I mean, if it's the cough, then you could also change vocal quality and intelligibility. Oh, I mean, it's huge. But it is such a new concept. I mean, and for novel for us to even be considering. This is not something that we've had to even think about in our practice. So, okay, so there's. I'm going to start by saying when you were like, I'm being a little cheeky right now, but so when you were listing off all of those possible symptoms, it kind of, and I'm not trying to be, well, I'm trying to be a little cheeky. Is like when you're listening to like, oh, possible side effects of this medication would be da 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 da, and you're like, wait, that one. So I mean, so that's my cheekiness there, but I mean, but it's true. I mean, there's so many symptoms. It has to be difficult to then to be able to connect that symptom with COVID-19.
And that's definitely the tricky part, is that we know that these students are out there and they're experiencing this. The prevalence rate is estimated to be between 2 and 10% of children who have had COVID end up having long COVID symptoms. So that's a lot of children across the US that likely have long COVID. And again, those are the numbers that we know from our studies. So it could be higher than that. But especially now, as we transition to a world where we're not testing students, it used to be every time you have like a cold symptom, right, you are testing for COVID. And we kind of shifted away from that unless you're like really, really sick, you test for COVID. But we find that long COVID, actually, we see it more in those who have had more mild cases of COVID than those who had more severe cases where they were, hospitalized or on a respirator or, things like that.
That was going to be my exact next question was, what about yeah, I was going to say, does it show up with kids that were identified with having it? But if you had such a mild case, you might not have tested, especially in the later, like you were just saying, like now or later in the pandemic, different areas of the world were more stringent and, and other areas were a little more lackadaisical on eradicating this. So I could imagine. So when you're saying that the percentage of long COVID persists or shows up in 2 to 10% of those students that had COVID, those are the ones that were identified with having COVID. But the numbers, I don't mean to be like alarmist, but it could be larger for students that maybe weren't identified as having COVID. Maybe, I mean, that some of these symptoms. So, I mean, it's a big deal. It's a big deal.
Yeah.
Yeah.
And to your concern about pinpointing it, it's really difficult. Not for all of the symptoms, but I think the biggest comparison to another group that I've kind of made in my head, that connection, is for students who have concussions. And in the last decade or so, we've done a lot of educating. Our teachers are more aware of it. It used to just be like, oh, you got hit in the head, you're fine, get back up, right? And now we have a lot of monitoring and return to learn protocols. And our students with long COVID have those same executive function deficits. They have that same difficulty and brain fog happening, but we don't have that like pinpoint of like, oh, you were hit in the head. And we might not even have a positive COVID test to go off of. And I want to make it known that it's not educators or SLP's area to diagnose this, but I think making educators and people who work with children just more aware of the symptoms that are out there so that they can raise their own little red flags of like, this isn't typical for this student that I'm working with. These behaviors I'm seeing, they're suddenly more tired, and trying to like piece that puzzle together so that they can get the supports that they need.
Exactly.
So-
We're seeing like almost a complete change up of a child's behavior in some cases, where some children may have been high achieving honor roll students and then are testing 2 grade levels behind following an illness. So
I could see that being a red flag, and I'm glad that we're doing this for SLPs. So like if you have student on your caseload that is presenting all of a sudden very differently, that this is
Mhm.
definitely one more thing to look into. It would be difficult for our younger kids that are coming in our preschool kinder. We don't have a baseline of their behavior, of their achievement, of their functioning. That would be much harder. And I like that you said that this is not something that SLPs are needing to diagnose, but we do want to discuss that this is just one more area to be to look into. And I know that I want you to get into the discussion of your case studies. Should we do that versus, because my next thing is I want to know what our role as SLPs are. So would it be easier for us to go into case studies or talk about the SLP role? What would make sense for you guys for us to start?
We could maybe start with the case studies.
Okay,
and-
perfect.
Okay.
Yeah, so there were some case studies that were published, and then our research was just about educating educators, anyone who
Mhm.
works with the school-based population about this. But Abby, if you want to share some case studies from the literature first, and then we'll.
Yeah. So what we found in our initial research was that children often describe their symptoms in ways that don't really match the traditional medical language. For example, instead of saying they're having cognitive difficulties, the child may say something like, "My mind is blank," or my brain feels so slow now," or even "It's confusing." When describing fatigue, they may say things like, "I'm too tired to speak," or "My head feels heavy," or "I feel floppy." One child even described it as feeling like an outsider on their own life, completely disconnected. And from what we've read in the parent blogs and children's testimonies online, a lot of these effects first show up in the school environment. So you'll see things like increased absences, a drop in academic performance, changes in motivation or mood, and less participation in school activities or sports. So really, it's not just about the symptoms, but it's about how these symptoms ripple out and impact a child's entire life.
Direct.
Oh, sorry.
So I was to say that directly affects school-based special education supports.
Yeah.
Because we are looking at how are their presentations affect them accessing their curriculum, accessing their educational day. That tied right in. Thank you.
Yes. And Carolyn, to your point that you brought up before, that it's important for us to look at these concerns for students on our caseload. From my perspective, I think it's even more important that we make sure those students not on our caseload who never needed speech before this have access to these services. The ones we're already seeing, we are already approved to help them. They're already on our services, and we can kind of adapt and move with whatever symptoms they have. But for especially higher achieving students who are suddenly confused as to why they're not operating at the same level, who have never needed special education supports or any type of related service before, making sure that, the frontline people, the teachers or the aides are kind of aware of this and know to refer to us as part of the team is really important there.
And okay. Oh, that does start a really big question. And I don't know if this is the time, but I'm just saying, okay, maybe we'll get into another case study. But really, and we need to come back to this question because my next question is that really the job of an SLP when it's almost like an acquired? Some of these presentations do fall under the scope of an SLP, but okay, my head's exploding because I'm like, wow, our plates are so full. When we're talking about being the case manager of a student like this, or just being maybe a related service and support, we can get into that maybe, but that just, yeah.
And to your point, I want to say that all these kids are going to end up on our caseload, right? For the biggest thing, it might just be time and giving them a 504 plan to be able to take more breaks and, be able to pause. And we know that rest is huge for them. So for a student who is struggling with fatigue, for them to push through the whole day. So they may need 2 or 3 days to recover, but if we break their day into smaller portions and we give them a 15-minute break between these chunks, we find that they are better able to come back the next day. And that's an accommodation that can come without SLP support. So it just depends on the presentation for the child. And I think that's a big strategy that can help probably a lot of them based on what we know that fatigue is a big symptom.
Thank you. Thanks for that clarity because that makes me feel better Because as a campus SLP, or I was like, oh my gosh, I don't want everybody listening like, okay, now we're all of a sudden going to have a 10% bam growth in our caseload. But this is such great
No,
information.
absolutely not. And the other job we have is as a consultative model, right? We can
Yes.
consult with these classroom teachers and say, hey, here are some strategies you can try with this student who is struggling. And then through that MTSS model, right,
Mhm.
only those ones that are still really, needing our help will end up being on our caseload. So I don't want any of our listeners to think, oh no, these 2 to 10% of students who have long COVID are going to end up on my caseload. That's not realistic.
Perfect. I just wanted to get that out there, and now we can continue. My anxiety is now lowered. But knowledge is power, people, and I think that that's the important part, that the reason why I felt that we really wanted to get you guys on School of Speech and really get this word out to our school-based clinicians is understanding and having this knowledge to share is so powerful. Okay, sorry, go.
So I guess, Abby, do you want to move on to the work that we specifically did next, or do you have another case study that you wanted to share?
I have a few case studies, but we can
Oh, we
also
love
move
we love a
ahead.
case study. No,
Yeah.
we love case study.
Let's
Lay
use
another,
the-
yeah, lay another one on it.
So these are actually from the Long COVID Kids Parental Organization. So these are parental testimonies that kind of detail what their children have been through. And I think that it's most helpful to kind of understand and be able to recognize, or maybe just have more awareness actually through hearing these real life stories. It kind of takes what we're learning in these medical journals and peer reviewed research to another level. A mother tells of her 12-year-old daughter's experience with long COVID. So her daughter was diagnosed with COVID-19 in the fall of 2020, and she experienced mild symptoms. And despite this non-critical presentation of the virus, she has continued to experience symptoms for years following the initial onset, such as cardiac, gastrointestinal, and neurological symptoms. Lynch reports fatigue as the most prevalent impediment, often leading to her passing out or falling asleep.
Oh, wow.
These symptoms, unfortunately, limit her ability to participate in physical activities and schooling. And the mother describes that her daughter glitches like a computer rebooting doing normal tasks. The mother tells of her daughter's difficulty retaining knowledge and taking notes. And this was, as I said, this was a significant alteration from her abilities pre-COVID infection, when she was a high-achieving honor roll student, but now she's testing 2 grade levels behind.
Okay, a lot of thoughts came.
Yeah.
First of all, the first one I had, or a question I have, the curiosity, is these presentations that she is having years later. Did they show up at the beginning when she first had the COVID, when she first had the symptoms and was tested? Was she experiencing these, or maybe not just her, but just in general? My question would be, do you have all of the symptoms right away and it just stays? Or do some of these symptoms then show up later?
So that's the thing. It's multisystemic, and it's very, very complicated. Some people have symptoms that from the initial acute virus that just persist. Others have an onset after. So it's just the regulation is it's 3 months after they have all these new symptoms that were not there prior to the actual infection. But it's very important to note that long COVID individuals, they may experience periods of remission or relapse or exacerbation of symptoms. So they may feel like, oh, I'm getting better, but then maybe come down with another cold and then be right back where they started. Or they may go to school or do something physically exerting and then an exacerbation of symptoms. But then they may go months and not have any symptoms either. So it's very interesting. It's very flexible, and it really depends on the person.
And we would like to say that school does not cause the long COVID symptoms. I know. I'm just being tongue in cheek because it sometimes, because I do feeding and swallowing specifically, I do dysphagia support for the whole district. And, sometimes I'm having to talk to a parent about that, we might want to make a change or do the safe feeding plan. And they're like, well, they didn't have this before. Okay, maybe school didn't cause it. But anyway, that's where I'm coming back. But what you're saying is that the task or the different environment, and that's exactly what I'm telling my parents, is this is a different environment, and the things that they were doing, how meals look like at home were this way. And now at school, the demand for just stamina alone of a whole school day could then trigger the symptom. It definitely, for those that have the fatigue, the brain fog, I was trying to write them all down, but anxiety even when you're now at school is showing up because of all of the demands that are placed on us at school.
Yes. It is not caused by the school
No,
setting.
but
It's impacting their daily life. And for children, school is a huge central portion of their life. So of course it's going to show up in that way. And as you said, school, there's a lot of demands that go into that. So it's definitely showing up in a functional way in that sense.
absolutely.
And that anxiety piece, there have been testimonials from children who express that, especially those who have more intermittent symptoms, is that they just want to know when it's going to end. And so that anxiety piece of not knowing, like some of them were like, even if it's like 3 years down the line, I just want to know that I will be over this. And so that weighs on them also.
And I think I've seen in the literature a lot and in the personal testimonies that sometimes children and parents feel like the child's symptoms are belittled or maybe thrown off, being like, oh, you're anxious or oh, you're defiant. And it's important to note that listening to all of these stories, these children do not want to be sick in bed. They don't want to be missing school. They don't want to be missing out on social interactions with their peers or playing out in recess or participating in their extracurriculars. These kids don't want that. They want to feel better. And I think even if somebody, an SLP or just a teacher just recognizes that a child, what they're going through is real and just has that awareness, I think that's a big piece. It's just really hearing their story and hearing their truth.
And having spent a long time focusing on just social emotional learning in general, I think that this is an area that we have unique training in as SLPs. We are trained to see behavior as communication, right? And our general education teachers, they get a lot of education and things they need, but they aren't always trained to view, especially when they're dealing with a class of like 28 kids. And it's just, oh, they're being defiant, I'm just going to send them out of the room. I have 27 other kids who are listening and ready to deal with that. And this is not just for long COVID, but across the board, our job in kind of educating everyone else around us of, let's look at this from a communication perspective and what are they communicating through this behavior. So working on more of those pieces can help as well.
I think that's powerful. And to piggyback on Abigail, when you were saying that these are children that were some of these high functioning, high performing, very social. And so, right, they want to go back to the way it was before. And then Cassandra, when you were saying the anxiety of not knowing, like, will I go back to the way? Do we have answers for that?
We do see that sometimes the symptoms, again, do get better. We've seen that throughout the research. But again, it kind of ebbs and flows where some children may have a full recovery or some may have symptoms for years. The symptoms may ebb and flow, depending.
And especially if they're already in a lower setting, like if they do catch a common cold, we're seeing those symptoms kind of come back, maybe not as severe, but certainly a slight relapse from where they were prior to getting that cold. And unfortunately, the research is still really new and long COVID is still really new. So long-term prognosis and projections, we don't really have, right? None of these kids who have long COVID have really made it into adulthood to have strong longitudinal study at this point. It's certainly an area of research that we need.
And thank you for doing the research and sharing that with us today. My head is just swimming with questions and just how this is impacting their overall learning and communication with these symptoms, which definitely executive functioning, their ability, this, when you say brain fog, being able to retain information, just cognitive. Yeah. And I liked when you said that they're not using those terms. They're using my head is heavy, or what. I was trying to write those down. They were cute, not cute, that we don't want them to have them, but
My mind is blank or
confusing.
Yeah.
Yes.
He's floppy.
Yeah, the
Well,
floppy.
that one.
Yes. And, right. And it's important that we don't just disregard students, their presentations, as they're being willfully disobedient with a child that was vibrant before. But I think it would be a red flag. My other thoughts were, there are so many other things that also would be scared it could be as well.
Yeah.
With such a dramatic change in personality or functioning, that's got to be scary for parents. And I think I don't know if it's Cassandra or Abigail, which one said, is how important it is for the awareness and to listen to the parents. Abigail, I think it was when you were doing the case study, that parents need to be heard. And the parents are such an integral part of school and the education that we do need to be. And I think as speech paths, we are, because if they're us, they're through the IEP process. And so parents are part of that IEP process, but we're looking at perhaps students that aren't on an IEP, and teachers are confused, or teachers are unsure. And so we do need to arm ourselves with this knowledge to be like, hey, here, these are some things we might want to look at as well. Some questions. And I know we're going to get into that, because I do want to get into like accommodations on what we can do as roles, but I love these case studies. Abigail, if you have another one, we'd love to hear it.
Oh, of course. So this was from a mother. This is also through the Long COVID Kids organization. So she's the mother of an 11-year-old, and she expresses how long COVID has left her son disabled. So the son experienced, again, a non-severe form of COVID-19 in the spring of 2021. Following a family exposure, and his symptoms prevailed for at least a year later. That's when the study came out, a year later. So the child presented primarily with neurological symptoms, including numbness and weakness in his extremities, fatigue, dizziness, headaches. He also had heart palpitations, abdominal pain, allergic symptoms. And like I was saying, multiple physicians belittled the boy's symptoms, labeling his condition as psychosomatic, as he had normal blood work and negative medical screens. But these symptoms were really controlling his daily life, his lifestyle, really impeding his functionality in daily life. So within his daily routine, he would have to take an extended period to get ready. He would take multiple supplements. He would put on compression stockings, eat carbohydrate-dense meals, and participate in physical activities. And his sequelae of symptoms have also led to a decline in school attendance. And his mother said, there just seemed to be so many things going on. It's like going down a black hole at a speed and you can't control it. And I think that's very powerful. And I think it's also very powerful to look at the comparison between the two case studies that we looked at today and how different they are. So
it's, quite frankly, frightening. It is. It's frightening as I'm hearing this. And so what can we do? Specifically, we are SLPs. We are here to help. We are trained to help. This is our calling, if you will. What can we do? Because I mean, you've painted a great word picture of the presenting symptoms and the impact that long COVID can have on these students. Let's get into, give us some tools of what we can do to help these students and these families and ourselves.
Yeah. So I think the first thing there is awareness. And that's what our research really focused on. Abby and I worked together, and we made a 20-minute pre-recorded in-service presentation on just exactly what you need to know about long COVID. And as we mentioned earlier, some of it's outdated now, but it was up to date at the time that we did this pilot study. We had about 30 participants. All were school-based professionals. We opened it up to anyone who wanted the information: aides, general education teachers, special education teachers, nurses, related service providers, anyone who might work with a child. And when we asked questions first about their experiences with working with students with long COVID or just knowing about long COVID in general. And we also asked questions about how useful that education piece was, that in-service. And none of the participants said they had a student formally diagnosed with long COVID, but about half said, oh, now that I know the symptoms, I might have had a student that I've worked with that had long COVID. So that awareness piece is the first step. We can't get to any other help, any other accommodations without that awareness going on first. And almost all of the participants expressed that the in-service was so helpful, provided such important information. I think 3 of our 30 participants specifically wrote, why aren't administrators seeing this? They need to see this. We need more education on this. And for SLPs, right, we have 1 foot in the medical field and 1 foot in the education field. And I feel like things always get developed in the medical field first, and then they later trickle down to the education system. And so we really have to take that knowledge that the medical field has done in looking into these symptoms and bring it to that education world in a way that is very easy, free of jargon, for anyone with any background to be able to understand and relate to.
Absolutely. And unfortunately, our 1 foot's on one canoe and 1 foot's on the other canoe in the water, and the water's moving us.
Wait, right? I think of an SLP right there.
Yeah, absolutely. So I just love that. And you did an interpus. You said it was 30 minutes long.
It was about 20 minutes.
20 minutes
We
long.
wanted to make it something accessible for teachers to do on their prep when they had, a free minute while their students were in a special or something like that.
And kind of like what we're doing today, the awareness of what the symptoms are. So we've got our awareness. Now we know we have those characteristics to possibly give us, And well, I guess sorry, I know I'm going to let you continue, but my thought would be as an SLP, if we said to the parent, would we be the one that would say, has your child had COVID? Have you?
I think it would more be a team approach.
Okay, thank you.
I'm noticing some of these symptoms in your child, right? It wouldn't be us suggesting long COVID. It would be I've noticed that they're really fatigued. They don't have the same level of stamina that they did, 2 months ago. Is there something going on? I would refer you to your pediatrician to talk to them, right? Because we can't diagnose these things.
Thank you. Yeah, I just wanted to reiterate that and to everybody that we are not here to say, hey, SLPs, when you see these symptoms, please tell your families that it looks like it's long COVID. Please go get a diagnosis. That is absolutely not what we're saying. But we are saying that we want to be part of that dialogue. We want a seat at the table to help these families and educators.
And similar for a child with ADHD, right? We're not going to go to a parent and be like, they have ADHD. We're going to say,
right.
Hey, we're noticing these signs. Maybe you should talk to, your pediatrician about this. There might be something else going on here.
And so that is so awareness is kind of two sides of it. It's awareness for SLPs, all of staff, not just SLPs, I'm sorry, all of the educational staff, to know that when a student is presenting differently like this, to be aware that that's not their regular presenting, to have the awareness to say that this isn't just a willful, that there is a change. And just when you see something, say something. I think that's what I've been trying to say. And I was falling over my words. When you see something, say something is what we're saying. So having the awareness of that. What do we need to do next?
The next I would say is probably building in that consult model, right? As you said before, not all of these children are going to end up on our caseload. But we need to provide those teachers with some strategies, right? Again, team approach. Let's get the school psychologist involved. Let's get the general education teacher, if they're already seeing a special education teacher, all the team members involved. And let's say, okay, we're seeing signs of this, this, and this, right? We're seeing this fatigue. Let's try adding more breaks into their day and taking data on what happens. Because at this point, at the initial point, we're not necessarily coming in a direct service yet, right? Because otherwise our caseloads would be huge and we don't need that. So we want to document kind of some of the things that teachers are doing. We can give them some of those strategies that we do with our students too to help with executive functioning. Let's break this task smaller and see how they handle it broken down for them. Let's, ask them to gauge how long they think this might take them and help them plan out how long this is going to be. And then if we're seeing that they're still really struggling, we might need to go the route of a 504 plan and get accommodations. And that's where we can get into a little bit of a tricky situation because a lot of these students don't have a formal diagnosis. We also know that some of these students, once they get to formal testing, they can actually test in the average range for standardized testing measures. And we know standardized testing measures have their faults, right? So it's really important at this point that we take a full case history. We get some of that dynamic assessment in there too. For a student who is older and verbal, we're going to want to hear from their perspective and see what they're really struggling with. And again, as a team member, we're going to be sitting there hopefully either saying, okay, maybe they would benefit from direct services with us. Maybe we can help support in designing the accommodations that they might need in the classroom setting. Maybe there's other services we need to talk about, right? That anxiety piece, that emotional regulation piece that they're suddenly struggling with might be a better fit for the school psychologist or the social worker to deal with.
Thank you for that clarity. I think what I also struggle being a school-based clinician is the thought that the symptoms could be fleeting or reoccurring. That's a difficult situation when we're looking at if when it presents itself, it rises to the level of the need for specialized designed instruction. And then that might be something that might be a whole nother study. But I do support the thought of, that these students need accommodations. Maybe if it rises to the level that it is affecting, if these symptoms are affecting them academically, educationally, just in their activities of daily living, that we need to look at putting in accommodations through a 504. But then we've got some of our kids, the students, that their symptoms would not just be fatigue, that brain fog, the cognitive, where now it's impacted where they are no longer reaching the potential that they had. It's
a lot. And some of those accommodations can help with that, right? Like a cognitively draining task is taking notes in class. You have to listen and process that information while you're motorically writing something down. And so maybe the accommodation of notes provided or a scribe might be able to allow them to not have to kind of multitask in that way, where they're better able to cognitively take in the lessons being taught. Another accommodation could be having some of these lectures recorded where if they need to go back and re-listen, it's available to them. So there are a few things that, we can get creative in our accommodations to support these students to try to prevent them needing that more IEP-based services.
absolute. I am all for not, putting accommodations in to take that barrier away so it doesn't impact them even further.
Right. And accommodations, we accommodate students who have fleeting symptoms all the time, right? Going back to my example of students with ADHD, they might be on their meds and doing great one day, and they might forget to take them another day, but they still have those testing accommodations because we don't know what they're going to need when that time comes around. And so our students with long COVID might be the same way. They might be really on their game one day, but they might need double time for testing another day, or they might need that scribe to be able to write down what they're saying to take, some of the labor out of doing the work.
Now, I do know that every student profile is different. I mean, just full stop. That's for every student's different. I get it. every student's, and then within that small population that is experiencing the long COVID, the symptoms are also very different. So I know my next question, I'm going to ask you to just kind of give us a list of accommodations, but only because I think it would be great for SLPs just to open and broaden our minds and give us some ideas of common. And we're not saying that each of these all your kids need all of these. We're not saying that, but it would just be helpful, I think, for me, if you, the ones you've given us so far, a scribe, I love that, to take away that huge task of having the mental task along with the motoric task of that. What were some of the other ones?
Extended time for testing or for assignments, a quiet location, breaks, frequent breaks and breaks during testing can certainly be an accommodation that can be on there. And we know that breaks are huge in supporting the fatigue portion of this. Accommodations for reducing the quantity of the work given, but still keeping that quality there, right? Maybe the other students have 50 math problems, but this student just has 10 that they have to do, but they're still at the same level of challenge going on there. Notes provided in class, possibly those recorded lectures, if they feel like they need something like that. Those are all, I think, reasonable accommodations that we can look into when we're trying to support these students.
Thank you. That just helps me kind of get my mind thinking of like what could we do and putting some of these accommodations. And I did
being part of the team doesn't mean much if we don't have anything to brainstorm with the team about.
Yeah, we need to have, we want that arsenal to bring with us to say, hey, have you thought of this? But I also liked the comment you said, how you equated that to a student with ADHD that has accommodations that don't always need them every single day. And your picture of students that then are medicated and regulated and they don't need their accommodation, but that is there for them when they do need it.
Yeah,
it's just making sure that our students are supported, because our end goal is for them to succeed and reach their potential.
Yes. And one of the things that we want to do when we're doing that dynamic assessment piece, knowing that standardized tests might not always give us the full picture, is seeing what modality of language they take best to. Is it verbal language? Is it written language? Some of them might have some of those reading deficits because of the concentration and cognitive process needed. Some of them might, because verbal language is fleeting, have more trouble with verbal language. And so building accommodations that way as well. Okay, well, if we know that they're struggling with the written word more, maybe we could have material read to them to kind of help with that.
Right, because we don't want to overdiagnose disability when it's something else going on.
Right.
Words to, yeah.
And again, promoting that independence piece, telling them this is there if you need it. Please tell us you need it. We are going to provide it for you. But if you feel like you could do it without this, we can always try it without this in maybe a low stakes setting first, where it's an assignment not getting graded, right? Getting them to advocate for when they need the support and when they're having a good day and they might not need as much.
Right. And to piggyback on when you said reduce the quantity, not the quality of work, because we're making sure we're not saying that we are modifying. This is not a modification. Modifications can only, no.
Yeah. Nope. It is just saying this student, it's taking them longer to do this. So what these 50 problems might take one student an hour, but our student, because of the fatigue and the concentration, needing to reread things multiple times, it's taking them an hour to do just 10 of those problems, right? And we want to hold them to the same standards and expectations, but we don't want them spending 4 hours doing the same number of math problems that it's taking everyone else. And I'm just giving math problems as an example. I know we don't always work.
No, it's not. I mean,
but we don't want them doing 4 hours of work that teachers are in their head planning for it to be a half hour or an hour of work. That's, cumbersome for a student that already needs more time to rest and recover.
Absolutely. And we want, right. Our intention is mastery of the subject matter, understanding of not just be able to do 108 questions.
Right. If you
Right.
master it in 10,
Right.
right? Like, and again, taking usually, a set of problems has, some easier type of questions, medium questions, harder level questions, and being specific of which ones you pick so that student still gets some easy, some medium, some hard. Teachers can then say, oh, you're struggling on this type of question, and maybe give them all of that type of question for the next assignment while the other students are still practicing, the whole set.
That's fantastic. That's a great little tool for us. I love it. I love it. Where would we go next? So we've got awareness, we've got accommodations.
Yeah, I think after that would be possibly looking into direct services.
Mhm.
If we're still seeing these accommodations are not enough, they're still really struggling, it would be recommending direct services with an SLP, or if we're seeing another area, another professional in the school district.
And if we were going to be doing direct services, then that would be the referral for a speech evaluation, which now goes back to exactly what you were talking about with the dynamic assessment and knowing what modality specifically would support a really valid representation of their needs, understanding what their symptoms are affecting and how to really get a good look at where their strengths and weaknesses are, because that's what we're doing. We're not we're not diagnosing. We're really looking at what are their strengths and weaknesses. What are their needs?
And this is not new to us. This is what we
No, yeah,
right? Like our students with learning disabilities, we don't always know what's going on, but we know, hey, they're struggling. We've tried all these other things. I think it's now time for, more direct services and some, specially designed instruction for them. Yeah, like we don't have formal medical diagnoses for any of these students, and we have to put all those puzzle pieces together and build, a present level of performance based on strengths and area of need. So this just gets right into what we've already been doing in the schools.
absolutely, absolutely. So I'm still very fascinated about this in-service. I kind of want to know more about it. And so you piloted this in-service, and tell me more about that.
Yeah, Abby, do you want to share? I feel like you haven't gotten a chance. I've monopolized the conversation on you.
Um,
But if you don't have it memorized, I have the data right in front of us, if that's easier too.
you want to go ahead? Yeah, go ahead and Matt.
Yeah, I came prepared. I didn't think I would memorize all of our data, so I have a cheat sheet here. But essentially, that 20 minutes is a boiled down version of things we've already talked about, right? It's what teachers can do, what strategies they can try first, what that referral process might look like, in addition to the education on what this, kind of looks like, what symptomology they might see, how that might affect everybody. And so I mentioned before we had 30 participant, not surprising because it's school based, that 29 of them were women, 3 were men, and 1 was non-binary, right? Kind of aligns with who's out there already. We actually did have 2 administrators who did this.
Good.
Most were related service providers. We didn't divide that up. I will say some of our recruitment was through like ASHA, the school-based SIG. We might have gotten more SLPs than other related service providers, but we had 7 gen ed teachers, 5 special education teachers. So we had 1 TA, 1 nurse, so just a wide range of areas of people sharing their experiences as well. 28% of participants have been diagnosed or know someone diagnosed with long COVID. So that's a decent number for this still being relatively new and unknown. As I mentioned before, most were not sure if they had worked with students with long COVID in the last 12 months, and we know that none of them definitively worked with students. So it was all like, oh, I might be seeing symptoms now that I know about this, but they have not encountered students with formal diagnoses. And that goes back to that diagnosis piece being really, really difficult. Let's see, what else do I have here? We had asked about school supports currently in place. Most, 19 of them, responded with no to my school has supports in place for identifying and accommodating students with long COVID. By and large, that education piece was lacking. Almost all 25 of our 30 participants responded no to my school has provided me with training for working with students with long COVID prior to our presentation. So again, the people that we need this information to go to, they're not getting it. What we really wanted to see is was this in-service, was this education a strong model for something that could be built out further to offer more trainings at a larger scale? Strengths of the presentation that were identified through our thematic analysis were providing information, organization, and clarity, and the length. So that 20 minutes they found to be really doable for them. One person shared multiple modes of presentation were helpful, as was sectioning off the presentation topic, so they felt it was divided very nicely. One said the information was very useful, and another said good lengths and lots of good examples. I know we're towards the end of our time, but it did raise some questions for our participants.
We want those questions. Yes, we do.
I figured you would.
Yes, we do.
So frequently asked questions that we got from the participants was, how can school-based professionals distinguish between truancy, social anxiety, and absenteeism? There's a lot of things that might cause absenteeism besides COVID. And again, there's not research into this field of how we best treat these students, but I think doing some of that, initial support and seeing if that helps, right? A student who's absent because of truancy or social anxiety, if you're building breaks into that day, that's probably not going to help their absenteeism, right? Starting with some of those supports and seeing, is this working? Is this support not working? Maybe that leads me to somewhere else. Another question was, how can we get this information about long COVID to parents? So I think you had brought that up, that, parents are a huge integral part of our team, and it might not, we don't want parents to be alarmist and being like, oh no, I think my child has long COVID, but we definitely want to be able to approach that subject with them of, please, I think just open communication in general. I want parents to come to the team and say, I'm noticing some, different signs from my child that I'm concerned about. Same as, the teacher or other educator should be able to go to the parents and say, hey, I've noticed some changes and I want to know if there's anything that's been going on. Have you talked with a pediatrician lately? Another question was, are there long COVID specialists? And what do you do if medical professionals in the community are not receptive towards the concerns of someone with suspected long COVID? And I think Abby has more information on that piece on long COVID specialists, if you want to share, Abby.
Yeah. When it comes to treatment, the National Health Institute in 2021, they came out with a recommendation for this integrated rehabilitation approach to treat symptoms of long COVID. So level 1 for individuals who actually do have a diagnosis of long COVID or are seeking one because they suspect that their symptoms correlate with this condition. There are these COVID-19 multidisciplinary teams, and there's actually a whole Excel sheet that just has lists of long COVID rehab clinics within the United States, delineated by state. It's a very helpful resource that I found online. I'm not sure what percentage of those are adult-based
Okay.
or pediatric-based, but it's definitely a resource to look into. And then level 2 would be these community team therapies. So that's where the speech language pathologist comes in. That's where maybe a pulmonologist or neurologist, the occupational therapist, neuropsych, cardiology, infectious disease, allergy. That's this multidisciplinary team. But level 3 is really coming down to the pediatrician and, as you're saying, the parental support, the parental care, and learning how to self-manage. So that self-management piece for maybe some of our older children.
And even that level 3 can be really difficult for some of our families. My time in the school district, I was in a very rural district that, had probably a very high percentage of low SES students who may not have had health care. So already that's a barrier for some of the students that we work with. So those that are already at risk are unfortunately still at risk. And those who just happen to luck out and be in an area where some of these specialty programs are might be able to better access some of this care. There is just that discrepancy that exists.
And thank you for just being aware of that there is that discrepancy, and that is something that we face and have to support. I appreciate that. What's another
That would be the ideal treatment plan, but
Right.
it's not accessible. And a lot of treatments, a lot of medical treatments in specialties like that or specific conditions, they really are so expensive, and a lot of time insurance may not cover that the services. So
Sure.
it's another deterrent.
Yeah, but as we are getting towards the end, I do want to end on we just kind of went "Meh, meh," but I mean, but that the struggle's real and we know it, and that's why we're here. That's why we are listening to the podcast and educating ourselves and keeping our craft up because we know how important it is. But I think wanting to just leave it on a positive note is that yes, this is real, but you've given us some wonderful, just wonderful strategies and armed us with some great tools for us to bring to the table to support our students, our families, our staff. Is there anything else that we haven't touched that we need to touch on before we?
I just want to thank you so much for having us on this podcast, because this is all we've been trying to do is bring awareness, and this is such a wonderful platform to do this on.
Oh, your passion is palpable, and we just love it. And I cannot thank you enough, both of you, Cassandra Natali and Abigail Sprague. I mean, just thank you so much for spending not only your time here with us for School of Speech, but your dedication to this research is just, it's groundbreaking and inspiring. I just want to thank you so much. And this does bring us to the end of our episode of School of Speech presented by Speech Therapy PD. I want to thank you again, Cassandra. Thank you, Abigail. I want to
Thank
thank
you.
everyone that's listening. Yes. So until next time, everyone, keep celebrating connections, communication, and the incredible impact that we as school-based speech pathologists support. So thanks, everyone. All right, bye.